Okay, so we are talking about insulin resistance here. Basically, I've already made this seesaw here. On one end you have insulin, on the other end you have glucose. Basically, your insulin comes from your pancreas, okay, and your glucose actually comes from the carbohydrates that you eat. So technically what happens in our body is that when we are eating food, and if I'm plotting a graph for your sugars, we have a low and a high reading. Okay, this is the low and this is the high. Low is normally around below 70, high up till 180. So technically your blood sugar is supposed to fluctuate between these ranges. Okay, so before meals you are quite low, and when you actually eat food you go up, and then before the next meal you're low, and when you are eating food you go up. You will not cross the 180 no matter what you eat. So technically your body has a lot of reserves. You add more carbs, you get more insulin. You add more carbs, you get more insulin. So that's how this balance is working, because this insulin can target the sugars. Okay, it can target someone who has diabetes. Someone who has got diabetes, they have one candy and they easily cross the high limit despite having a lot of insulin. So what's happening there? Basically, you have got this job to control the sugar, and that job is being done by the insulin, and two soldiers can do this job very nicely. People who are very healthy, the job can be done by just one soldier. Now, if this job is being done by one or two soldiers, it's considered job well done. If this job is done by 3 soldiers, 4 soldiers, 5 soldiers, the job is still done. What's the job? To control the sugars, but it's not a well done job. Now, where was your scenario? Your job is done by a whole army of insulin. 116, one of the highest insulin resistances that I have ever seen. Okay, there was no diabetes, but there was a lot of excessive insulin in your body. So whenever we checked your sugars, we gave you a glucose tolerance test, you went up, but you didn't really cross the diagnostic threshold of diabetes. But the quantity of insulin released to keep you there was massive. Now what does this do? Basically this extra, for example, another way of looking at it, like we have to clean this table. It is 2 persons job. Okay, you and I can do that, or you can do it alone. It's an easy job. We hire 116 people to clean the table. Table will be very nice and shiny. Would anyone be happy? No. The management would say this is a very lazy workforce. That's exactly what happens in insulin resistance. So basically, the excessive insulin and is called insulin resistance. And what does it do actually? It keeps your sugars fine, but it also attracts fat. Now this fat can be ending up in your liver, giving you fatty liver and the inflammation, and that's exactly what we saw in the bloods as well. And it is also like chicken and egg, what came first? Whether the fat gave you insulin resistance or the insulin resistance made you obese. Now this is like a lock, okay? It's a bit of struggle to try to lose weight when you have so much insulin sitting in your blood. Sometimes we use things like metformin, and I believe we had used that, glucophage. Now it is a very old drug. It has been there in the market since 1954, all right? And this drug actually basically targets the insulin resistance. The idea is to bring this number down, okay? It's not a potent drug, it's a weak drug, but it does a good job. Now the idea behind this drug is actually to reduce the amount of insulin your body is releasing to keep the sugars under control, so that we open up this lock. And if someone is doing a lot of exercise, eating healthy, and weight is not moving, with metformin sometimes that lock is open and they see their effects become better. Now what happens on the long run? Let's look at another way. Now I am doing a health screening program, okay, and I'm running a health screening program every 10 years. I'm doing some bloods on people, okay, and I'm actually doing a screening test. The screening test is for diabetes, which is glucose, and I'm checking their blood glucose, which is G here, and if the blood sugar is fine, we are happy. Suddenly the blood sugar goes up, and I say, okay, you have been diagnosed with diabetes, fasting glucose, because it's too high. Now for the same person, if I had tested their insulin from the beginning, okay, you would be surprised to see that the insulin went up 20 years before someone had diabetes. Okay, now what does this imply? It implies that the pathophysiological processes that lead to diabetes, they begin 20 years before the sugars actually go up. Now the problem is that diabetes doesn't give you many symptoms. Okay, we are pretty good in capturing pre-diabetes. Why? Because we have got dedicated cutoff. You may have a glucometer at home. We check the fasting blood glucose. If the fasting blood glucose is above 125 milligram per deciliter, we say you have diabetes. If it is below 100 milligram per deciliter, we say there's no diabetes. If we say, okay, you have got a blood glucose of 105, 110, we alert you. We highlight this to you that, okay, you have got pre-diabetes. So people are warned. Now what goes wrong is that when we see your blood sugar is perfectly fine, we send you home without a warning while you're actually sitting here with significant insulin resistance. There's another blood test called HbA1c. That's the 3-monthly average. What does that mean? Basically, when we are doing blood glucose checks, now there's one profile here I've drawn here. There is another profile which could be there. So another person could have pretty good fasting, but when they eat, it goes up. Before meal, it comes down. They eat, it goes up. So every time they eat, it goes up. Either they're unhealthy eater or they are just sensitive to carbs. So if I take an average, so the average for the red lady would be here. If I take the average for this blue man, it would be here. So basically, the HbA1c is nothing but a 3-monthly average. And we have a dedicated cutoff here. If the HbA1c is above 6.5%, it's diabetes. If it is below 5.6%, it's normal. If someone comes like 5.8, 5.9, 6%, so we say you have pre-diabetes. So we alert people. Now you don't end up in this box overnight. In order to reach this box, you have actually completed a journey of 20 years reaching here. Now, this is a dynamic thing, okay? It's not end of the word if someone has reached here. It's not great. We can say that the ship has sailed, but again, there's a lot more that can be done. The reason behind that is that there was a fantastic study done in the UK, and that was called Direct to Trial, okay? This was an amazing study. Basically, originated in Newcastle. They were the first people who decided that they actually advocated a diet. They said, take the Newcastle diet and your diabetes would go away. It was a fantastic program. Initially, we were very much dubious about that, but it worked. They gave a specific diet to people with diabetes and the drugs were stopped. It was so fascinating that the team from Glasgow, Newcastle and Cambridge, they all joined together, and this was an NHS funded program, big study. They gave a peculiar diet to patients who had diabetes and the drugs were stopped. But at the end of 2 years, because it was a 2 years program, there was relapse of diabetes, so it did come back to some patients. So when we opened the data, we actually found that patients whose diabetes was older than 3 years, they were back on drugs. Patients who lost less than 20 to 25% weight, they were also back on drugs. So what message it implied? It told us that, okay, there is a window of opportunity. And that window actually closes after 3 years of your diagnosis. Okay, so 3 years after diagnosis of diabetes, you still have a window to intervene. But what was that peculiar diet? It was a very specific diet. Later on, we called it Cambridge diet. Most people know about that, but it was actually the Newcastle diet. It was less than 600 calories a day. They were milkshakes, yogurts. The idea was to technically starve people. So the message we got from this study was that, look, if you have got metabolic dysfunction, don't give up on yourself. You have actually got 3 years to act on it. Okay? How do you act on it? You need to lose weight. It doesn't matter how you lose weight, but it does matter how much you lose weight. So you need to lose 25% of it. And they actually starved people by calorie restriction. You can starve, you can exercise, and you can do whatever you need to lose weight, whether it is bariatric surgery or some of the new drugs. Now, it's very hard to lose weight. Okay, so that is the whole thing about insulin resistance. If we talk about that, the weight is much more complex. If I tell you about the weight, how it works, and how your body regulates, it's actually very tricky and very challenging. We have screened you for a lot of things. Your weight kind of sits in a triangle, okay, And the reason I draw a triangle is because it's simpler to understand and explain to patients. There are three factors to which contribute to your weight. One from you, so if you move the triangle like that, okay, so the thing pointing towards you is what do you eat and what do you do in terms of exercise. So these are patient dependent factors. The contribution from them is actually just 10%. All right. Now this is lifestyle. So this is lifestyle. So that's the contribution to your weight from your lifestyle. Of course, this is an important contribution. I wouldn't say that we ignore it completely, but at the same time, I wouldn't say that this is the only thing which will make a difference. The thing towards me is, okay, look for metabolic problems. So I have insulin resistance, I have diabetes, I have thyroid dysfunction. I screen all patients for these things. Why? Because these are common, and sometimes you don't have any other symptoms with these conditions. Okay, basically you may just have like insulin resistance, which is excessive insulin, or sometimes sugars can give you weight gain, and thyroid dysfunction. We did screen you for Cushing's and other stuff. I don't screen that for everyone unless there are certain features, and the reason behind that was excessive insulin resistance. Acromegaly, again, excessive growth hormone. I don't normally screen, but your scenario was a bit different. Now, the contribution from this end is also 10 to 20% on your weight. Now, the total weight that you're carrying is actually 10% contribution from lifestyle, 10% to 20% contribution from the pathologies. Then where is the massive weight coming? That's genetics, okay? Now, we get one gene from mom, one from dad. Now, I do know mom, so I know there are weight-related issues there. That, of course, we cannot blame the parents, but this is something coming as genetics. Now, there's another factor which not many people would talk about, and that's called epigenetics. Now, epigenetics is very tricky, it's very challenging, it's not well understood. When we are born, we have areas in the genes which are actually manifest. They give us the color, the shape, the skin, the hair. Then there are dormant areas which are sleeping. Okay, the dormant genes do wake up in our lives. That's why different pathologies develop in different times in our lives. What wakes them up, we don't know. There is a hypothesis about a list of things like endocrine disruptors. Okay, now this is actually quite a huge list, and I'm actually very careful using this term because the list is so massive. Sometimes you can be a bit paranoid. Everything is an endocrine disruptor, like fumes from paints, pesticides, fertilizers, BPA, plastics. Our exposures to endocrine disruptors begins when we are pregnant. Well, our moms are pregnant with us. So there's a lot of exposure to endocrine disruptors. We are seeing strange things nowadays: autism, ADHD, childhood obesity. So there is a role of endocrine disruptor. You don't get organic food. Global migration. Okay, so you flew from one country to another. That's an endocrine disruptor. The same food, the same bread, the same chapati. If you were in South Asia and you come here in the Middle East, it has a different influence on your body. Now, the thing is, we cannot get away from endocrine disruptor. We can't get away from the genetics. We have to play around. You have to play around and do what is necessary, because your body has the ability to regulate everything. Okay, it regulates the sugars, it regulates the weight. Okay, and regulation of the weight happens in a very peculiar way, which is sometimes again not fully understood. But as you asked me, so I'm going through that detail with you, that in your brain there is an area, we call it the hypothalamus, and the hypothalamus will be deciding how your weight should be. If you have 2,000 calories, for example, your hypothalamus would say, okay, I'll retain 1,000 as fat, I'll burn out 1,000 as our heat, and this will give you a kind of a fixed metabolic set point. So that is your kind of metabolic set point. Now, this will be keeping your weight at a peculiar figure, let's say 70 kilograms, and it will try to resist a change. Okay, if you go up on the scales, your body will try to bring you back. Let's say you bring your weight to 150 kilograms, your body will drag you back where you were. You go down, your body will bring you back up where you were. So the set point is a genuine reality. It's actually an evolutionary thing. If you look at animals, they also have a set point. They're not too fat, not too skinny. So technically, your body actually fluctuates between two figures. That's actually a set range. and that set range should be within the normal BMI range that we talk about. Now, if someone is supposed to fluctuate here, but he is fluctuating there, we know there's a problem with your top limit of the range. And that's exactly what's happening in most of the individuals who are struggling to manage their weight. Now, when there's a dysfunctional top limit, I cannot change this sensor and bring you back there. We know that this sensor is malfunctioning. You can ask a slim friend of yours, try to bring his weight up to where your weight is, and you will see it's very hard. Bringing the weight up is also very hard. Now, how does this sensor work? It's quite dynamic. It makes changes with your daily routine. So, for example, you go on a calorie restricted diet, the same diet that the Newcastle team did. So that's why that's a failure program as well. I wouldn't say that I would use that as a sole intervention. We go on 600 calories. Your body realizes, the metabolic set points realize something's not right. There was a lot of feasting before, and now there is famine. So the body will try to survive. So instead of burning the 1,000 calories, it will say, I will only burn 100 and retain 500. So you're retaining quite less, so you will lose weight, but then you will plateau. Okay, and eventually when you go back on the 2,000 calories, the burner is down, your body will come back up. And that's exactly our story of life. So 10% down, 10% up. Now, if you try to look at different weight loss interventions, okay, so we have like diet, we have drugs, we have exercise, not to forget, and bariatric surgery, mom is saying. So basically, they all have different contribution. For example, diet can give you almost about 5 to 7% of weight loss. Exercise around 7 to 9%. Maybe some people are more sensitive, they can do more. You combine them, you can get about 12%, maybe 15%. So you go down 12%, you're back up 10%. So kind of square one. Bariatric surgery, always considered the gold standard for morbid obesity. It gives you 25% weight loss. Still those people can have 10% weight gain, okay? But they're happy because they are much lower than where they were. Now, drugs that we talk about, some of the new drugs that we have, they actually give you a fantastic weight loss. They can give you something close to bariatric surgery. And these are the drugs that we talk about, the GLP-1s, the glucagon-like peptide, glucose-dependent insulinotropic polypeptide. What are they basically? Now, these drugs, they are successful because they are crossing the 10% weight loss. Okay, they are going to, but remember, whatever intervention we do, your dynamic sensor will be adjusting. If you go too fast, your sensor will drop down the burner. We don't want that. We want to go slow and gradually, so we are not failing on the long run. And we also want consistency, okay, because we know that this is kind of a genetic kind of obesity. Okay, so this is not something which will go away. It will stay, it will persist, it will always try to drag you back to square one. If you are using one of these new drugs, what are these new drugs? We already know, and you have used some of them. You are well aware of how they work. These are actually call them glucagon-like peptide or glucose-dependent insulinotropic polypeptide. So this is basically, these are sensory signals. These are signaling pathways. Okay. Now, when you eat food, you think that your eyes have seen the food, and your brain should know that food has come in your body, but that's not the case. These are signaling pathways, okay? These are signaling pathways which work like text messages in your body. When your intestines receive the food, they send out a text message to your brain, to your stomach, and that text message is actually the GLP and GIP. What is that text message? So basically, the text message is as simple as we can describe. Food is here. Although you have seen the food and you have eaten it, but unless your intestines sent out the signal, your brain will not act on that fact that you have seen the food. So this text message is a must. Okay. Now, if I have to send you a text message, I need your mobile phone number. In the body, it doesn't work this way. It's a community message. You sent a message across the whole community. Those people who are relevant stakeholders will recognize the message and pick it up because of these receptors. Okay. So when the intestine sent out this community message, food is here, the brain picks it up, oh, food is here, so I'm going to switch off the appetite now. The stomach picks it up, it says food is here, so I'm not going to allow more food coming up. So if you have more food, you will be throwing up. So things like drop in appetite, things like you're feeling too much nausea, okay, and things like sometimes people can be vomiting as well, things like you are having a lot of acid reflux. That's how it actually works. Your intestines can be very slow, so sometimes they just slow up things to the extent that people can have constipation. So that's how this signaling pathway works. So when we use these drugs, we are aware of these things which are going to be a physiological effect of drug. But this drug forces you to use the calories that your body is not using. Okay, so technically the body, which should be retaining your weight in this kind of normal range, and it is actually retaining high, we pushes it down. We push it down that, okay, start retaining your body. There will always be, I have not changed the sensor. So the malfunctioning sensor is still there, but I have rewired it. I have utilized some signaling pathways to utilize something which is already inside you. So these drugs, they work very, very effectively. They are excellent drugs. There's nothing wrong with them. And reaching this weight was not your fault, because you may be blaming yourself, maybe mom's blaming you, but your contribution is only 10% here. Okay, reaching this BMI is partly contributed by this, but that's only 10%, partly contributed by this, mostly the genetic stuff. And it would be unfair for me to ask you to lose at least like 40 kilograms weight, because it's not going to happen. And even if it does happen, it will fluctuate back where it was. So you need some assistance with that.